Dr. Shalin SHAH?
Yep.
I think so.
Okay, good morning everyone. So I'll be presenting about a modified incision for inferomedial orbitotomy. So why do we need to approach the inferomedial orbit? So we have certain orbital tumors and lacrimal sac malignancies presenting in the inferior or the inferomedial orbit. Then we have maxillary and ethmoid sinus malignancies who are asymptomatic and they present with proptosis and outward deviation when they invade the orbit. Then we have failed DCR cases probably associated with a large mucocele which are often invading the orbit. And then we have orbitoethmoid fractures which involve the medial wall and the floor of the orbit. So these are our conventional incisions for orbitotomy. Here we have the four medial and inferior orbit incisions. Two of them skin, the Siegel and Lynch incision, and two of them perilimbal and transcanalicular incisions. The problem with these are that we don't get enough exposure when we want to approach the posterior orbit, or we need to extend them along the inferior lid to create kind of a swinging lid crease incision to approach the inferior orbit. So we got inspired from our ENT colleagues. This is the classical Weber-Fergusson incision which is used for maxillectomy purposes, where a subciliary 3 mm from the lid margin incision is taken along the lower eyelid and then progressed along the nasolabial fold. So we modified it into a smaller incision exclusively for the inferomedial orbital lesions. And this includes a subciliary component, horizontal part, and a vertical oblique incision along the nasolabial fold. So I'll directly move on to our cases. So this was a prospective study where we included sequential cases of the indications I mentioned before. And so this was a case of a 41-year-old male patient swelling below medial canthus around 3 centimeters on superficial examination, and he had a history of failed external DCR 2 years back. As we can see on imaging, there is pneumatization of the lacrimal bone actually. So it was an agar-Nazi cell there, and the DCR surgery was performed where only one of the table of the agar-Nazi cell was removed and the other table was not removed. So we can see that the lateral wall of nose, which is pointed with the red arrow, is actually intact. And this led to a large mucocele which was expanding into the orbit, into the medial orbit, displacing the globe upwards. So here we went ahead with an external DCR with a complete mucocele excision using this incision. This was my first case. So here I did not meticulously suture the orbicularis back to the medial canthal tendon, and we can see some amount of tear trough deformity which has formed here. And so in the further cases, we had meticulously anchored the the orbicularis to the medial canthal tendon, which gave a much better cosmetic outcome. So this was again a similar case where an agar-Nazi cell mucocele had developed following a failed DCR surgery. And this was the endoscopic view. This patient, we could have an endoscopic view. So adjacent to the axilla, we can see the bulge at the agar-Nazi cell. And again, the patient underwent a similar surgery. Now, the second group of cases we took were lacrimal sac malignancies. So again, a middle-aged male patient, failed history of DCR. And this was the imaging where we see an expansile, well-defined lesion which is compressing the globe. On incision biopsy, it came out to be adenocarcinoma of the lacrimal sac. And these are the post-op pictures where a meticulous suturing was done of the orbicularis, and we can see a very good outcome since it was performed a few weeks back. I don't have a long-term follow-up for him. And we have used this even for large orbital lesions. This was a malignant melanoma spreading into the orbit. And this was combined with the ENT person for maxillectomy, superficial maxillectomy. And this is the scar we got after exentration and maxillectomy. Another case of nasoorbital ethmoidal fractures which had spared the nasolacrimal duct and lacrimal sac. So the patient was actually patent on syringing but had enophthalmos with floor and medial wall fracture. And this is the appearance at 3 weeks. We can see a very faint scar at the site of incision, and we could easily place a large medpore implant in this. And this was one of our very recent cases, a maxillary sinus malignancy invading the orbit. So here again, the similar approach was used for an incision biopsy. And so in conclusion, we get a better exposure and we can save the canaliculi and lacrimal sac, except for lacrimal sac malignancies. There is minimal scarring and proper excision. So thank you.
Thank you, Dr. Shalin. Good approach.
It was done in ophthalmology or ENTOT?
Ma'am, all of these, except the last case, which was a maxillary sinus malignancy, they were done in ophthalmology. We invited our ENT colleagues over.
Especially the one with the tumor, we could have done it with the help of a frontal flap. Exentration with frontal flap could have been done.
Yes, ma'am. So it was around a 75-year-old lady, and we had explained that we could reconstruct it. We even gave her the option of a temporalis muscle flap for the socket reconstruction. But actually the family was not ready for a very large, multiple incisions and multiple site surgery. So they just wanted an exentration, and that's it. Since it was not spreading behind and her PET was fortunately negative, she had no liver mets. So we just did an exentration with maxillectomy, and she's doing fine. We have a 6-month follow-up.
Did you do a frozen section?
Yes, ma'am, we did frozen section, and we had multiple tissue bits taken from the superficial cheek and from the nose and from the forehead just to confirm negative biopsies, and then from the orbital apex as well. And we had negative, then we just closed the skin over the bare bone.
Regarding lacrimal cases, did you use a stent?
No, ma'am. Actually, that patient, we have removed the canaliculi, the inferior canaliculus, the sac and everything. Right now he is awaiting his radiotherapy. And after the radiotherapy, we'll have to plan a conjunctival DCR because the sac and the inferior canaliculus are gone. And on the last visit, the upper canaliculus had developed stenosis because of the post-op scarring. Thank you, ma'am.